Okay, thank you everybody for coming tonight to Hospitals 2.0 Mega Challenge. We have an exciting agenda planned and a great crowd. Thank you for managing to navigate Manhattan traffic tonight with the Christmas tree lighting. I heard it's a little bit crazy out there, but that's New York, and that's why we're all here tonight, because we believe in something very passionately, and that's about improving healthcare. And Health 2.0 New York City, which is the largest chapter of the 70-plus Health 2.0 groups, meetup groups in the world today, is dedicated to really helping startups really find capital and get to the next level, and that's really what we do. Between events and kind of connecting up experts and mentors with startups that are looking, entrepreneurs that are looking to really help refine their business plans, find the capital, get the help that they need, get customers going, do the research that they need to do. We know it's not easy to start up in health. We're not talking about video games, so a lot of regulatory issues, a lot of challenges. So that's really the point of this group, is to really get this ecosystem going, and I think we've come a long, long way in the last 2 years in terms of the investment in healthcare. And I think we're going to continue to build momentum, and I'm excited tonight to have a great all-star judges tonight, as well as 6 startups that are going to pitch. But first off, I want to really thank our sponsors tonight. We couldn't have this event without them, so I really want to thank them. First off, Goodwin Procter, hosting our event tonight in a beautiful office space tonight. So I want to thank them. Goodwin Procter is one of the, if you don't know them, one of the leading international law firms and technology companies group. They're highly focused in the healthcare and technology space. They represent over 1,400 technology companies, so they certainly are well aware of the challenges and requirements of technology. They have helped over 200 VC and private equity companies investing in technology. They have one of the largest or leading life sciences practices in the US. They were Law Firm of the Year in the Biotechnology Law by US News' Best Lawyers. And Goodwin takes a lot of pride in terms of understanding their clients' business. So they're very client-centric and really work hard to help their clients. And they have a fantastic track record in terms of helping clients get through IPOs, mergers, and acquisitions. And I would like to introduce you to Steve Davis, who is chair of the firm's technology companies. Steve, would you like to come up?
Anthony, I'd like to welcome everybody to our house here. I know it was cold and raining outside, but let me tell you, in here, it is sunny and bright, and it's going to be an exciting night. I also would like to introduce one of my partners, Jeff Klein, who's in the back, who's just absolutely a terrific and important part of this practice as well, and I know Jeff welcomes you as well. I was actually going through the internet, and I pulled up an article from the Wall Street Journal called "The Time to Innovate is Now." And it says, finding innovative ways to deliver healthcare has never been more important than it is today. It goes on talking about the 35+ million people who are going to be entering into the healthcare system, in a system that's already strained by rising costs. It talks about trying to rein in healthcare costs, being absolutely critical if the government's going to deal with the long-term budget deficit. And it goes into the question, or it asks the question, how will an increasing number of people get quality care at a cost that a nation can afford? And it goes right on to say, the answer isn't hard to figure out, it's innovation. And that's what brings us all here today. Innovation in such an important space. We are delighted again to be hosting this. I do want to thank Health 2.0 for organizing tonight's event, because I feel that for any type of venture industry segment, it is so critically important that there's a forum where the various constituencies of that industry, whether it's investors, whether it's providers, whether it's entrepreneurs or purchasers of healthcare, can meet, can connect, and hopefully do business together. Also like to thank MedStarter, didn't mention them, for co-sponsoring and acting as the catalyst for tonight's event. For those who don't know much about MedStarter, I urge you to speak to Anthony after the program, or to go online. MedStarter is a part crowdfunding platform for innovative healthcare ideas. I call it Kickstarter on steroids. Dozens of companies have received funding, customers, or press as a result for being on the MedStarter platform. It's part connector. Over 50 partnerships have been developed through the MedStarter platform. MedStarter is also Pod Accelerator, where experienced, committed mentors in the healthcare industry are actively assisting MedStarter companies in their successful development. And MedStarter has created just a vibrant network of patients, doctors, institutions, and investors who together drive healthcare innovation better and faster than before. Last but certainly not least, I'd like to thank Cipher Health for co-sponsoring this event. Cipher Health develops and implements analytical healthcare IT solutions that improve quality care and increase efficiency in the healthcare system while delivering real value to providers, payers, and patients. And that is, the holy grail of what innovation is all about. They're a true health tech innovation success story. So with that, again, I welcome you all here. It's going to be a great event. I turn this back to you.
Great. Thank you, Steve. Okay, I'd like to introduce you to our esteemed judges tonight. And you're going to hear a lot. We have a great agenda. So we're going to start out hearing from Fran Griffin from CMS. And then we're going to go to the pitches and the presentations. And with this, we had a lot of input at our last event that we wanted to reserve more time for the audience to ask questions of not just the startups, but also the judges. So we've left hopefully 40 minutes where you guys can ask questions and find out what are the priorities for hospitals today and how are the startups navigating their scaling approach and how they're finding their technology received in the marketplace, what results are they getting. So we're going to give you guys some time to fire questions both to the judges as well as to the startups. So we have a couple mics that we'll pass around, and I think it'll be a great conversation, great dialogue that we'll have. So introducing the judges, starting right here with Steve Berman, who is Director of Business Development for Montefiore, a subsidiary of Montefiore Medical Center. As you know, they've been expanding rapidly over the last year in New York City, and Steve heads up their business development and venture group. And we thank you, Steve, for being here tonight. So that's great. Thank you. And then next we have Ms. Oriella Boyer from New York Presbyterian. And she is the CIO, Chief Information Officer in New York, as well as of the NYP healthcare system. As you know, they've expanded rapidly up into Westchester, most recently in my neck of the woods. So incredible expansion, and we're excited to have New York Presbyterian join us tonight. So thank you very much. On the right of her is Randy Chung, who is with Cipher Health, which is one leading technology company that has hospital clients in 35 states. So they have a great track record and success, and I think for the startups, I think you'll learn a lot from Randy today, how he and his company have really managed to get to the next level of success. I'm sure it hasn't been easy, Randy, right? On the right of Randy is a good friend of mine, Peter Fischoff, who is a great New York City advocate, who was the founder of Medscape and is currently on the board of several great healthcare startups. One recently, MedPage Today, which was where I came from most recently, was the general manager of MedPage, which was acquired by Everyday Health. So thank you, Peter, for being here tonight. On the right of Peter is Eric Liam, who heads up Mount Sinai Innovations and is responsible for making their investments in new technologies and navigating a wide space of innovation within his organization. And they've been a true leader in New York City in terms of really innovating, and you'll hear some more from him tonight. So thank you very much for being here tonight. Okay, so I think it's interesting that, when you think about and you look into the future and you think about the next generation that's kind of coming up, what is the delivery of care going to look like, okay? And how is it going to be different from where it is today? So my son, who turned 12 yesterday and blew out his candles, his only two requests for his birthday presents were, one was a Chromebook. That's what he uses at school, and he wanted a brand new Chromebook, and the other, of course, was a video game. But I was thinking when he blew out the candles and he was making a wish, what was he wishing for? And obviously being in healthcare for 25 years now, obviously I wish for him and that when he turns 50, he has a healthcare system that is innovative, efficient, and really does an incredible job of taking care of patients and caregivers in terms of helping them through their acute and chronic diseases. So that's really what I wish for him, and I think that's what we're talking about tonight, is how hospitals who are on the front lines of delivery of care can really innovate and change the way they practice medicine. So to talk a little bit about innovation, I'd like to introduce you to Fran Griffin, who is with the CMS in Washington, and she's going to be talking about what Washington is doing in terms of innovation and how that affects everybody in this room.
Okay, thank you. Okay, so this will be a whirlwind tour of the innovation strategy for CMS, which is very comprehensive. And so please feel free to reach out to me after tonight if you have follow-up questions. I'm easily found on LinkedIn for anybody who's interested in connecting. So we all know that the current state is not working. It's a producer-centered, volume-driven, and pretty fragmented setup. In fact, just announced this afternoon, a couple of hours before I left the office, because I work downtown here in New York, that the healthcare spending for 2013 analytics came out showing that while spending slowed and is at lower levels than it has been in a long time, we still spent more in 2013 per person than we did in 2012. Slightly over $9,000 per capita in this country, which is more than double than any other developed country, and not for the same outcomes when you look at things like life expectancy. So we're working very hard to move towards the future state, as I know all of you are. So I'm just going to give you a flavor of a little what's behind the CMS strategy. So hopefully many of you are familiar with the Triple Aim. This was created by Don Berwick, the founder of the Institute for Healthcare Improvement, and Tom Nolan. If you go to the Institute for Healthcare Improvement website and you just put in Triple Aim, you'll find tons of information on this if you're not already familiar with it. The concept of the Triple Aim is focusing on those three dimensions you see: population health, the patient experience of care, and per capita cost simultaneously, working on all so that not one is sacrificed at the expense of the other. So everything we're doing in our CMS innovation strategy is taking into account now population health, yet at the same time making sure that we're doing so in a way that does not add cost to the system, at least remains neutral, preferably brings it down. And we, of course, want to make sure that individuals still have a great experience of care. And for us on CMS, since we're an insurer, experience of care includes access to care, which is insurance coverage as a start, but so much more, as many of you know. So when we look at the determinations of population health, as you can see here, first one we can't do much about. The rest we all have some element of control over. So this is where a lot of our efforts are going. Individual behaviors, as we know, are very difficult to move. There's a lot of other things that, working in partnership, where healthcare providers and insurers are working with community organizations and public health, and the private sector can work on social, physical environments, and health services, which include access to and delivery of care. Because we have lots of data to show that 40% of the contributions to premature death relate to behavior. They don't relate to other things that we can't control. And the genetic predisposition is only 30%. So lots of opportunity there as we think about it. So the CMS strategy, and this is literally right out of our strategy document, you'll find it on cms.gov, focuses on better care and lower costs, improved prevention and population health, and expanded healthcare coverage. And all of the models that our Innovation Center is testing, which I'll share with you in a moment, are focused around this concept of better care, lower costs, prevention, and population health. Our current system, as you know, is designed as a diagnosing illness and injury system. We really don't focus, nor do we pay for, keeping people healthy, and that has to shift. So we're not saying don't take care of people who have illnesses and injuries. Of course, we have to continue to do that. But if we put a lot of focus on prevention and population health, maybe less people will have chronic illness and injury, and so that we'll be able to shift and use our money more wisely over time. So this is a very long list that I am not going to read because all of this information is accessible, and I'll show you where in a moment. The Innovation Center, which is located in Baltimore, was created under the Affordable Care Act, and the sole purpose of the Innovation Center is to test new models of care delivery and payment. So we have providers all over the country who are working in the models that you see listed here in collaborative groups to test new ways of delivering care. Certainly, this is only a small piece of the pie of innovation in these areas happening all over the country. So the first one, as you can see, accountable care organizations as an example. We have several groups, including the Pioneer ACOs and the Advanced Payment ACOs. Lots of ACO work going around the country besides what we're doing, but this is one important aspect of it. Working on primary care, bundled payment approaches, capacity to spread innovation, funding awards, the Healthcare Innovation Awards, round 1 and 2. Some of you may be familiar with that. Some of you may have even applied for them. Those were funding opportunities, as well as other demonstrations that are working on specific initiatives. The slide is slightly out of date because we have a new initiative that was just announced within the last few weeks called the Transforming Clinical Practice Initiative, which is in an application phase right now. So I can't speak to the details other than to let you know that it has been announced and there's lots of information on the Innovation Center website. So we've got thousands of providers working with us on these initiatives. Many beneficiaries are included in the programs. If you go to our website, which is here, you can read about any of these initiatives. You can see who's participating. You can see that locally. If you want to know just who's working in New York and New Jersey, since that's local, you can find out who is working on what. It's all in there. It's exportable. There's a database in there where you can export information. You can also sign up for news updates and other things. So that's a very quick high-level overview of what the Innovation Center is doing. I worked there directly for 2 years. Now I'm based at the regional office here in New York, which is down at Federal Plaza. And what we'll be doing in the coming year is we're trying to start building networks around the country to connect all these innovators with each other and with other innovators. So I'm hoping to do some exciting events in this area in the coming year and hope to see some of your faces again. So that's it, and I think we've got maybe a moment or two for questions to try and keep you on schedule. Okay, all right, we got one.
Can we get tech?
The slides?
Yeah.
I gave them a PDF of the slides, so I told them that the PDF could be shared with all of you, yes.
We'll post it up on the meetup.
And most of the information I shared is available on that website as well. Okay, thank you very much.
Thank you, Frank.
Thanks, Anthony.
Okay, we will share those slides in an email that we'll send out to the meetup group after the event. Also, you can be tweeting. As you can see, we have Twitter Live. So as you see the presentations today, please feel free to tweet at hashtag H2NYC. So as you get inspired by some of the pitches, spread it across the internet. Okay, so we're going to get started today, and I think you're going to get. It was really hard. We had over 45 companies apply to pitch tonight. And it was, I think, of all the events we've done, Adam, who's my partner with MedStarter, you know, we went through these with the judges and really tried to pare it down. It was not an easy selection process to get it down to 6 companies. And they were hopefully going to get most of these companies live on MedStarter within the next week or two, if you want to just talk to that a little bit.
Absolutely. So hi, my name is Adam Griff. As was mentioned before, MedStarter is a crowdfunding platform specifically for healthcare. But it really goes way beyond the funding. It's about connecting you to the entire healthcare ecosystem and finding collaborators from all the stakeholders in this complex system, from patients to frontline clinicians, to healthcare systems, to payers, to investors. We connect your ideas and help you find the right customers and the right partners to help you launch and find success. So please, if you have any questions, one of the questions we often get is, well, you know, my product, my company, my startup isn't really made for a crowdfunding site. I don't have a Pebble watch. I don't have a product I can give to a bunch of consumers. That we found ways that and strategies that will work for no matter what kind of healthcare startup you are and help you connect to your partners and find funding. So please come talk to me afterwards, and I'm happy to discuss your startup. And I would also encourage you, if you are a startup, to tweet as well. It's a great way to introduce yourself to everyone here tonight and around the world. Thank you.
Okay, first up is board rounds. So Benjamin, if you'd like to join us up here. Please meet Benjamin Jack, who's the Chief Executive Officer of Board Rounds Incorporated. And you're up. Let's get you started.
Thank you, Anthony.
Okay.
My name is Benji Jack. I'm co-founder and CEO at Board Rounds, and I am very excited to be here tonight to talk with all of you. How's everybody doing tonight? Is this microphone on? I said, how's everybody doing tonight? There we go. Thank you. So at Board Rounds, we send patients home from the emergency room quickly and safely. So when I was a medical student at Cornell, we would send patients home from the ER with discharge instructions that they didn't understand. And in fact, about 80% of patients don't understand their discharge instructions, and only 20% of patients that need follow-up after emergency room discharge get that follow-up care. And as a result, about 40,000 patients a year die within 7 days of being seen in an emergency room. That's more than the number of people killed in car crashes every year. And so we built Board Rounds to make sure that patients leaving the ER get the follow-up care that they need. So let me tell you how it works. So hospitals tell us when patients are leaving the ER, and then we reach out to patients by text message and phone call to help coordinate care. There's no patient-facing app. It's really a service that we're reaching out to the patient to help them get the next steps that they need after they leave the ER. Although there's no patient-facing app, there is a provider-facing app, and providers can use this app to access our service very easily. So if a hospital distributes this app to its entire emergency room, whether that's doctors, nurses, or even a concierge type of person on the ER floor, it instantly puts in place a turnkey follow-up program for all of the patients leaving the ER. And the benefits of that are enormous. It increases patient satisfaction. It decreases medical legal risk for patients that might worsen after they leave the ER. And perhaps most of all, it keeps patients in network for further revenue opportunities for the hospital system. And actually, we're not charging hospitals for this service. The service is free for patients and for providers. Insurance companies pay us a portion of their savings when we reduce long-term costs of care, and that's our business model. It's actually very similar to the economics of an emergency department itself. Patients love this service. These are actual comments that we received from patients, spelling mistakes and all. Thank you so much. You've been amazing, made life a lot easier. I didn't have to do anything. So patients respond very well to it. We're already working with 2 hospitals and 2 insurance companies. We're a team of 4 right now, and that's us. That's Board Round. So thank you.
Questions from the judges? Board round?
Yes. Can you tell me, how do you interface with the EDs to get this information?
Right.
And how transparent is it and easy for them to use so that this does not add another complexity to their already complex day?
Sure. So we can receive the information about a patient being discharged in any way that's convenient to the hospital. That could be an ADT feed, if that's the easiest way for the hospital to set it up. But the reason that we built this app is that we can distribute this tool to a few providers in the ER. It doesn't have to be doctors, it could be support staff, and give this a shot for 1,000 patients, 10,000 patients, and really demonstrate the savings that we generate. And then, as a next step, do a formal EMR integration. So that's the story with the app versus getting the data somewhere else.
What happens to patients, ER patients who are admitted to the hospital?
So right now, we are focusing on patients discharged home from the ER, and in the future, we may expand that to patients that are admitted as well.
Okay, and if a patient is in the ER, say waiting to be admitted, but that bed never comes, so they just stay in the ER, happens all the time, what happens then?
So if a patient is technically admitted to the hospital, even if they're boarding in the emergency room, we're not servicing those patients right now. We're serving patients that are admitted to the ER only and discharged home.
Okay, thank you.
Because this is a one-way feed, as you mentioned, not from the patient back. You assume if you're texting, they're getting this and that they're adhering or listening or reading to what the text message indicates. And there is no feedback to make sure that that in fact is happening or to follow up. So it's not a care management tool. It's a notification tool that you hope will get them to take some kind of action.
No, so we're providing a simplified care management function on the back end. So when I say we reach out to patients by phone and text message, it's not only automated. Part of it is automated, but there's also human intervention. So if a patient doesn't respond, that might prompt a phone call from us.
How are you measuring savings?
So right now, we are looking at completion of follow-up appointments. We've been able to increase follow-up rates from about 20% to about 60 or 70%. And we're in the process of additionally measuring revisits to the emergency room and looking at how many patients are kept within the hospital's network specifically.
Okay, suppose I'm a patient, I go to an emergency service, I'm out of my, I'm up in the country, I go to a local emergency service. I don't want to, I'm going back home. I don't want my follow-up in that emergency service. I want it near where I live. It's not really keeping me, is it useful then, or is this just an in-network, keep them in jail kind of tool, or?
So it's still useful then. We're certainly not taking patients away from their normal primary care doctor. In that case, we would arrange follow-up with your PCP back home. The situation with keeping patients in network is for patients that are otherwise unassigned.
When you reach out to patients and you identify patients with issues, how is that handled?
So right now we're not providing medical advice. So we tell patients that, we have triage protocols in place that if there's a problem, instructing patients to return to the emergency room, or if appropriate follow-up, say, well, you have an appointment on Monday, talk to your doctor about that then. But we're not going so far as to provide medical advice.
So what happens to what information is collected then, and how is that aggregated and who sees it?
So we're aggregating that information and providing it back to the hospital in a dashboard.
Great, thanks.
How is this better than just emailing the patient and letting them respond or following up that way?
So we contemplated emailing patients. We decided that text message and phone is the lowest common denominator. Often the patients who are non-compliant or non-adherent after emergency room follow-up are lower income patients that might not use email regularly. Again, that's another form of communication that we might add in the future.
So I understand that, but why do they need your system to do that?
Why not just email every patient leaving the ER?
Or have another kind of a follow-up system. I'm not clear on what the advantage is.
I think that maybe what I'm downplaying is the concierge aspect to the service on the back end, that it's not simply sending a message to the patient saying, thanks for visiting the ER. We're actually going so far as to schedule interventions for the patient. That could be scheduling a follow-up appointment. It could be scheduling transportation. It's helping the patient get where they need to go.
We have time for one last question.
So I'm concerned about a couple things. Scalability, concierge, you said you're 4 employees? 4?
That's correct, yes.
How many phone calls can you actually make as four people? How much validation do you have from your customers that the savings data that you're actually collecting is convincing? For me, I don't think it would be. How many customers do you currently have? What's your current revenue stream? Things like that. So it seems to me that it'd be interesting to hear a little bit more about exactly who your customer is. It seems that it's the insurance company, and exactly how they feel this is going to work, exactly when they're going to start paying you, and exactly what you need to demonstrate for them to do that.
Sure. The short explanation is that you're right. The insurance company is the paying customer in this case, and that we are providing specific services for patients of the insurer or members of the insurer to facilitate follow-up. I think we're almost out of time. I'd be happy to go into more detail about the exact economics and tell you more about our existing paying deals
with those insurers.
Okay. Thank you, Benjamin.
Thank you.
Okay. Next up on the hot seat is Pinaki Dasgupta. Please join us. He is the Chief Executive Officer of Hindsight. Welcome.
Thank you. Good evening. I'm Pinaki Dasgupta, co-founder and CEO of Hindsight. Imagine the future of healthcare. Imagine a future with personalized treatment plans that leverage an entire population's healthcare history, constantly updated in real time. Bad outcomes get prevented, spending gets optimized, healthcare just gets better. At Hindsight, we are building one of the finest artificial intelligence platform for that better healthcare. Numerous studies have shown 1/3 of US healthcare spend is preventable. And in that, unnecessary service happens to be one of the big ticket items. So our software predicts and prevents unnecessary services being rendered on patients. So as the healthcare business model changes, and you just heard the payment model is changing, in that scenario, we and our software helps ACOs and health plans predict, manage, and improve patient outcomes more profitably. Here is how we do it. In healthcare today, the data are trapped in silos. So if you look at the structured data, look at your EMR, ambulatory, and inpatients, they don't talk to each other. And then you have administrative data, pharmacy, lab. You can even bring census data. And they don't talk to each other. And then 80% of the unstructured data is trapped as clinical notes. And in 21st century America, we communicate via fax messages between two entities in healthcare. Yes, that's true. And those fax messages are again trapped. So what we do is we, in essence, have created an artificial intelligence platform with natural language processing to get those data untrapped, normalize those data from multiple source systems. Then we apply natural language processing to harmonize, commonize the data, and machine learning and predictive analytics to garner actionable intelligence that trigger a workflow improvement and enables payers, providers, and patients' communications. So let me get all this to life with a real use case. So here is the patient, Linda. She had an excruciating headache. She sees her doctor, Smith. Dr. Smith wants to do a brain MRI. Anna is the healthcare payers, insurance company. So just to ensure no unnecessary tests are performed on patients like Linda, she has put together what they call a adjudication team, utilization management adjudication team. In this, she has hired nurses, board certified physicians, and the way it works is Dr. Smith sends that pre-auth request via fax. The nurses reads and analyze those facts, creates summarizations for the doctors to make those pre-auth approval or denial decisions. As you can see, it takes a long time, it's archaic, inefficient, and expensive. So we have trained our software to read and analyze those facts, and the decision which used to take days and hours now is made in minutes, and over 35% cost savings. We are rolling this out to cover 5 million lives across America. We just closed a multi-million-dollar deal last week. And this is the team behind Hindsight. I was partner at Accenture, led one of the largest and most ambitious big data undertaking in the world. Rebecca is patient care director at Presbyterian Hospital. Adrish was at Oracle. And Gopal and Brad is postdoc candidate, research associate professor in UMass Amherst. And of course, our advisor is Startup Health. Thank you.
Two quick questions. One is, you have IP on this?
Yes.
You do. And the second is, this is a bolt-on tool onto a data warehouse, data lake, that then extracts the information and presents it on a dashboard, or presents it exactly how do I access this?
Yeah, so our software resides on Amazon Cloud. And there are two ways of doing it. We can either recreate it within your firewall if you desire, or we can take all your data into our platform. Now, many cases, like you are nodding your head, that's not possible. So we actually recreate within your environment. And if you have the data warehouse, that's great. But if you don't, it doesn't matter. It's a one-time integration fee. We take all the data from your historical data one time, and then we build an integration point to get the streaming data live going forward.
Do you use particular vocabulary services? Vocabulary services, do you use any?
When you say vocabulary, we are not into speech recognition here. We are only looking into.
But you're using NLP, so I guess what you're saying is you're not, okay, I get it. But who's your competitors? I mean, I know of a number of companies that are kind of in stealth mode trying to do the same thing. There's been some patents that have been filed in this space. I haven't been following it for a little while, for about a year and a half, but what's the competitive landscape look like?
As far as utilization management piece that I just shown, I haven't seen anybody who has done it. There is one case study where IBM Watson has tried it at WellPoint, but I don't think it went beyond pilot, but I don't know. I may be wrong.
Okay, I have a couple of comments. I know this is a brief pitch, but I would suggest you not use headache followed by an MRI as a case presentation. It's sort of like sending somebody in for a colonoscopy after they're complaining of farting. It's, it's enough to send shivers up a lot of people here. The notion of just doing that without a lot of testing. There are hundreds of NLPs out there. Practically everyone who I talk to who's graduated with a degree in informatics has written an NLP, and they all say that theirs is the best. They take unstructured data from notes and they put them into structured data in EMRs. They convert them to codes and stuff like that. What's so special about yours that makes it any of the other difference? MIT has an NLP shootout in which there are hundreds of NLP companies, all in the medical space, who are competing for doing it better. So what's different about yours? I don't get it.
Yeah, so can't talk about others, what others are doing, but we have been piloting this for a year now, and we have done extensive studies with fax messages, 36 pages of fax. We analyzed it, and as I said, we are now rolling it out to 5 million lives, and this will be 20 different imaging studies. Our customer, which is a Fortune 1000 organization, extensively validated our results, had seen our prototype, and then only is writing us the check. So as far as our software is concerned, it's world-class, and it's already been proven, and we are going live.
The one customer is in what market?
This is one of the leading radiology benefit management companies in US.
And so you have one paying customer?
That's just one for utilization management, but I have other clients too.
No, but again, for the product that we're talking about right now, you
Yes,
have
that's one first client, yes,
Okay.
exactly. We are a year and a half years old, so this is our first client, yes.
How many pilots do you presently have going?
3.
3?
Would like to do one with you.
Yeah, thank you. Is the goal that any of them will be writing a paper based upon the results?
One that we won the Pilot Health Tech New York City, the idea is to write a paper, yes.
For them to write the paper?
Together.
For them to write the paper?
Together.
For them to write the paper?
No, sir, together.
That's
we
a
will.
problem, but okay.
Together, we will do it.
That's a problem, okay.
Not sure whether to ask you or one of the other companies. I think I may have noticed one of the members of your team is also a member of one of the other teams here presenting tonight. And is that true? He's a co-founding member of...
Not that I was aware of till now.
I think it's Clinsis, perhaps. He's one of the developers. There's a fellow in the upper right-hand corner here. I think he's one of the co-founders of one of the other companies presenting tonight. No? Okay. Someone with the same name or exactly the same name, potentially?
I'm not aware, really.
Okay.
No, I don't think so, but I'm not
Okay,
aware.
good. Good, just had to make sure.
One more question. Anybody? Okay.
Thank you.
Very much.
Thank you. Appreciate it.
Okay, Dr. Marty Coyne, please come up. Dr. Marty Coyne is the Chief Medical Director of High Tech Solutions and another proprietary solution. So I think you had some good questions to follow up on. So
I didn't know this was an NLP seminar. I'm glad to find out it is. I would have changed my whole talk. And maybe I'll change my talk on the fly. And there was one other interesting thing from hindsight. You'll see there's a similarity there of the same doctor bedeviling us. I'll leave that for the slides. Okay, I'm Marty Coyne from High Techs.
just hit the right. Yep. There you go.
First, I'd like to tell you a little about our team. I'm the CMO, Jerry is the CEO, Per is the CTO, and the three of us all have formal trainings in medical informatics. Jerry and myself are MDs. So I want to tell you a little about my background. I practiced gastroenterology for 40 years in Los Angeles, and I wish they had been sending me patients. I'd still be practicing. I also ran something called the Cedars-Sinai Physicians Association at Cedars for many years. And it was in that capacity that I really came to understand the value of good medical data in influencing physician behavior and improving patient outcomes. And in fact, that is the mission of the company we formed, to improve the quality of the data going into the EHR and the quality of the data coming out. Now this is where it becomes an NLP seminar. We too have an NLP engine, proprietary. And I think everyone understands now what NLP does. It takes data from unstructured free text fields and puts it into structured fields in the database. But there are several problems in getting good data into the EHR. I want to focus on them. The first is the architecture of the EHR. Again, by now you're familiar, structured fields and unstructured fields. And in the Epic Health System that we work with, 20% is structured and 80% is unstructured. And these formats don't communicate with each other. And here's the same guy who was bedeviling my a colleague before, Dr. Smith. He's ubiquitous, you know, he bugs every medical informatics person. But there's two things on this slide that I want to point out about the physician workflow. When you talk about getting data into the EHR, physician workflow is paramount. In the bubble, patient has CHF with SOB for 2 months, treated with Lasix, etc. That's free text narrative. That's the way doctors are trained to think, and that's the way they like to enter data into the medical record, whether it was text-based and now it's digital-based. That's the way they like to work. The other thing I want to point out about Dr. Smith is this gentleman is an orthopedic surgeon despite the long stethoscope. I can tell by his habitus. He's upright in the command position. That's the way a lot of doctors like to be, like to work upright. They don't like sitting in front of a desktop PC. And that's a crucial aspect of workflow of getting good data into the EHR that have to take into cognizance. This is a screenshot of our Epic program called Salient Scribe. We're built into Epic, and this shows on the right side is the free text field for Epic. A doctor dictates in. On the left is what Epic calls the note reader field, in which the structured fields of problem list, medication list, and allergy list come up. This program is now implemented. 2,000 doctors around the country are using it, including Hackensack Medical Center, Riverside, California, and several places in the Midwest that you don't know. Actually, Evansville, Indiana, and Grand Rapids, Michigan. Maybe some of you know them. But you're New Yorkers, so.
No blue.
We're here today to talk not about Salient Scribe, but a new product that we're trying to develop. This is a mobile application. We call it Salient Voice. And the reason why we're trying to develop it is it goes back to Dr. Smith and his work habit of standing upright and being mobile. And this is the best way that we can think of to address the issue of getting data into the EHR in a physician-friendly format. Salient Voice application uses our NLP technology, uses our voice recognition technology with speech command that's being used in 10 centers in Houston area. And it uses the Salient Scribe auto-population into the Epic database system. So it uses proven, established technology, and we're porting it to the mobile platform. Next few slides, I'll show you how Dr. Smith would do it. He can open up the application with a voice command. He can get information retrieval on his patient and similar patients with a voice command. He can drill down for more information on his patient. And now he can dictate in his progress note. At this point, he has full edit capabilities over his progress note. He'll click OK, and the final progress note will be posted. And now he's afforded the opportunity of auto-populating the database. So the database problem list, medication list, and allergy list will come up in his handheld. He has the option here of editing it or sending it to the EHR. If he clicks send to the EHR, it'll go to the EHR server in Epic on the hospital server. And he's done. I think at this point we'll take some questions.
So I think looks like wonderful technology. I hope it's as good in the real world as it is in the PowerPoint, but forgive me for being skeptical. I often call it the epic fail based on my observations of clinicians struggling to use this truly horrible piece of enterprise software, which is responsible for lots and lots of clinicians pulling their hair out and patient injury, as far as I'm concerned. Anyway, how many versions does this work with? All versions of Epic?
2014.
So just the 2014. So
Yes,
people
yeah.
who have earlier versions are
Right.
kind of out of luck. Okay, that's not
Well,
surprising.
Epic has plans to roll it out to all their clients within the year.
But first of all, I think you've done a lot of things here really very, very well, and I want to congratulate you for that. The first, the observation that clinicians like to do their work when they're standing up and walking around and not sitting behind a terminal is a very profound and important observation, and one which is the reason why many, many clinicians are so frustrated by the systems that they are saddled with by people who don't really understand what it feels like to take care of a patient. So congratulations on that. I think if this, if this does work like you, as well as you show on your PowerPoints, it's a real improvement, and be looking forward to seeing it in the real world.
Well, thank you for those comments. Actually, as I said in my talk, I have 40 years of practice in medicine. So I really know what's important to a doctor, what was important to me, and have to be user-friendly. And that's what we're trying to do. As far as it working, well, one of the good things about Epic, or maybe the only good thing, is that they're rock solid. So if something doesn't work, it can't be rolled out to their clients. So in that sense, there's a degree of assurance. Whether we can get it to that point, you're right, that's always the
We're
challenge.
talking about a piece of software that in most installations doesn't even have a search engine. That's how bad it is. I mean, if an equivalent piece of software were introduced into the consumer world, people would just be up in arms, and it's kind of amazing to me that they've been as successful as they had. Sorry, Epic salespeople who might be in the world, in the room, but thank you for trying to make this miserable piece of software better.
All right, so how do we bash the hell out of it?
We'll try to.
Can I ask some questions
yes,
here?
go ahead. Aurelia.
So, what you're pitching is not your salient thing, which you've already developed. It's moving it to mobile.
Right,
That's
yes,
what your specific
that's the next
pitch is.
step, and that's why
And
we're
so
here
can
tonight.
and moving it to mobile is a great idea. I think the workforces are mobile and we're behind on that. So I would concur that that's a good idea. Have you thought about expanding it? You'd only do 3 things: meds, allergies, problems? It's a
Yes,
very limited set.
It is. We can do 18, 20 fields. We're working with Epic, and a note reader currently only supports 3 fields for meaningful use.
Okay, well, you
Next
might
year-
want to try another vendor.
We would
for
love to.
starters.
We would love
Just
to.
a suggestion. And do you use vocabulary services?
Yeah, sure.
Can you tell me which ones you use?
SNOMED is the main one that we work with.
Okay.
Well, we use RX Norm for medication, so the medication RX Norm, the allergies
Ever
were
heard of
SNOMED,
UMLS?
ICD-10 was.
UMLS?
Yeah,
I think you might want to know. Okay, thank you.
okay.
How many pilots have been done so far? How many people have actually used it?
2,000. 2,000, not the mobile.
No, I mean,
No,
you're
not
pitching
mobile.
the app, right?
Yeah, the mobile app is in laboratory development. We have a prototype. We haven't rolled it out to any real medical users yet.
Is your sole go-to-market strategy through Epic?
Well, it depends. On the Salient Scribe, Epic owns the PC territory.
Right.
That's their territory. On the mobile app, one of the reasons for being on MedStarter is we want to open it up to other doctors who work with other EMRs, and hopefully they'll ask the EMRs in their health system that they work with to let us work with them. So that's a strategy.
You may have mentioned it, and I apologize if I missed it, but who's going to pay you? Who's the real customer?
The hospitals.
And how many conversations have you had with hospitals to date about,
About which product? Salient Scribe, our flagship product, maybe 30 clients we're potentially dealing with. We have six going now.
Right, but you're pitching the app, I thought.
The mobile app is in development, right? We're pitching the app. We haven't really, in terms of willingness to work with us, Hackensack wants it as soon as it's ready to go.
Right, but speak to the economics, right? What are the economics of the business?
The economics of the business, we do it per physician per month. So the mobile app will be, in essence, thrown in with Salient Scribe, and we charge around $50 per physician per month, and the hospital has to pay.
Okay. I mean, one of the things that I would comment in general on the pitches so far is a significant lack of market information. What do you think? What is the market? What do you think your revenues could be? just some basic projections would be actually,
Yeah,
if you're gonna do this and you're really gonna be asking people for a check, you're gonna have to get much more detail. on that.
absolutely. In other forum, we have presented business projections, but not in this particular forum. Perhaps we made a mistake. But for example, there's about 300 Epic installations. If we get a third of that, our revenues will be close to $1 billion.
I mean, one of the things that I would love to hear from what I like to hear from small companies that are coming up with ideas for businesses is, I've spoken with this many potential customers. This is why they want to buy my product. This is how much they will pay me for my product, and this is why they will be willing to pay that much. This is what my market size is based on a certain amount of market penetration. Those kinds of things.
Yeah,
So,
no, that's excellent. That's the reverse of the way doctors and engineers do things, but
it's the way actually
it should be done.
Successful entrepreneurs
Yes, it should
actually
be done.
figure out.
You're absolutely right.
Don't build a product and then
Yeah.
find your market.
You got it.
Find an opportunity, then build the product.
And I wouldn't be an MD if I did it that way. So.
Fair enough.
Thank you.
Okay, next up is Rakesh Parimi. Please come up from the founder of IDSRIP.
Okay, so how is everyone doing? Couple things. First off, unfortunately, I don't have the full marketing slides in this. I was told this is a 4-minute pitch. I will go through the material, however. And second, probably more interesting for those of you who probably got bored of hearing about NLP, there's nothing about NLP in this, right? So, this one? All right. Okay, so my name is Rakesh Parimi. I go by Rick. I am an MBA student at the NYU Stern School of Business. I have a master's in computer science. This new venture was founded by myself and some other people. And it is right now participating in the NYU Stern's Berkeley Center of Entrepreneurship Challenge that is running right now. It happens to be a quarterfinalist. So I'm presenting here tonight, and once again, I'll be presenting on Friday at NYU Stern. I have 6 minutes there, a couple more minutes than I have today. Okay, so what am I here to talk about today, right? So, and why would it matter probably for those of you who are in the audience and probably for those of you who are sitting here? I'm not sure if it's going to appeal to everyone who is sitting, but hopefully some of you, all right? So Fran was here. She was the first one who spoke, and she talked about CMS, right? She talked about 9 that were on the slide, and then 10 actual, innovation strategies that CMS is undertaking. Does anyone remember what was the first one that was on the list? ACO, thank you. All right, someone was paying attention. So the reason I say that is, from my own experience that I've seen, and based on market research that I've done, my observation and the insights that I derive from those observations tell me that there are a few things that are happening in this space of ACOs, right? We all know there are 3 different ACO models, right? The Medicare Shared Savings Program, the Pioneer ACO, and the Advantage model, et cetera, right? And maybe there are flavors of these that are being implemented today. What really matters, however, is, okay, so all of this is happening. Why is this happening? This is happening because CMS, everyone believes, the government believes, that this is what is really going to help us achieve the triple aim, all right? So we're convinced about that. But is this really working today? All right, so there are quite a few ACOs that we have in the system today across the country. We're going to have a lot more ACOs that are trying to be formed next year and year after that. So obviously, everyone believes fundamentally that an ACO is what is really going to help us achieve the triple aim. Reduce the cost of care, right, and improve the quality of care, right, and help drive the efficiency, right? That's the whole premise behind ACO. ACO is one of the things that is going to help us achieve this population health management objective that we have, right? That pretty much every hospital, payers as well as providers, ambulatory clinics, everybody is going after this, right? Everybody has a vested interest in this. Patients have an interest in this, as well as physicians also have a vested interest in this. Everybody has some stake in this, all right? Now, one thing that I have here at the bottom that talks about healthcare analytics market, and I'll move on to the next slide as I talk about that, is that All right, so the healthcare analytics market is going to be more than $20 billion, by the end of this decade, and it's growing at a pretty, huge rate. But what is really happening in that space, and why do I talk about analytics? Because I believe that analytics providers, software providers, are probably the biggest threats or competitors, if I call them, to what I'm doing. All right? Now, that includes the likes of Oracle, IBM, Tableau, SAP HANA, IBM Watson. Anybody who is doing anything with analytics comes close to this, in my opinion, on different scale. Okay? But I call all of what they have as substitutes. And why is that? That's because they sell you software. You have to buy the software, and you have to necessarily do something with it. You have to install it in-house, and you have to do something with it. It takes about 2 to 3 years before you see some value coming out of it, and that's time, material, so on and so forth that has to go into it before you get some product built that you can use to analyze your data. But again, when you talk about an ACO, an ACO has a few different flavors to it. I, as a provider, may be looking to go to an ACO. I, as a provider, may be looking to acquire another provider or a smaller provider like an ambulatory clinic to become an ACO. How does that help me? How does it help me that I have to invest 2 to 3 years to go into something, or even if I have something, to do something with it in order to get the value out of it? It just doesn't work. Economically, it doesn't work, right? Also, before you go into these ACO models, you have to necessarily have dialogues and conversations. You're dealing with information that is not available, right, in that core sense for you, the provider, the payers, to do that analysis. I'll go into more details, right? So that's where I call the solution that I have is basically the best paraphrasing is a CRM for healthcare analytics, right? It is customer relationship management applied for healthcare analytics. If you guys understand that, I'll be like, thumbs up, right? So I'm not going to go in, that's it, right? I could probably stop here, but then I have to explain to you what that CRM for healthcare analytics is about. All right, so the next 3 slides are going to go through the product, concept. We spent 3 weeks building this. It's a prototype. I have 0 sales on this right now, okay? But I am in conversation with one of the leading hospital systems here in New York City, also in conversations with one of the leading payer systems that we have in the country. So I do have good news that they are interested. They are helping me develop this concept, make sure that it actually works. And how is it going to work is as follows. You have ACO. What's an ACO? Is a legal contracting entity that is formed between a provider, healthcare, hospital system, and a bunch of payers, right? So you can have n number of hospitals, so on and so forth, ambulatory clinics, etc. My observation and analysis tells me that there is something fundamentally lacking the way things run today. People first off look at things, they do a lot of spreadsheet analysis, and therefore there's a lot of inaccurate analysis that is done today. And they are not including all of the necessary elements that have to be included, all of the dimensions that have to go into this. I am absolutely not concerned in this whole thing about the actual data. I literally care less about what the actual member information your ID is. I care more about the demographics. When I put all of these data sets together that come with all the blocks that you see on this slide here, there is huge amount of information that comes in, right? I'm talking about information I'm going to get that will be collected from the employers, from the health risk assessments, from entities like Weight Watchers. When you pull all of that data together, there's a richness that comes with it that will help make intelligent analysis about the performance of an ACO, right? So this is what the product basically looks like, right? It's there out there. It's in beta version. You can go to that link, try it out. It's free for the prototype, obviously. Basically, there are n number of dimensions, 60 dimensions that we have identified for all of the things that you see on the slide on this thing here. And of course, I admit this is not it. The full production version is going to be much more humongous than this in order to address everything, all the complexities that come in this world of ACOs, right? So you basically select all of the dimensions. You define what is you're going to be including or excluding in your ACO model that you believe you have access to. right? So you basically define the criteria. It's an 8-step process that you go through. Step 0 is you self-discovery based on what I know. It's an online collaborative tool where, say, the COO of the ACO can work with the COO or someone else from the payer system, and perhaps your CMIO from the ambulatory clinic, so on and so forth. Everyone has different pieces of information that is of value for an ACO to be successful. That is what this does. It helps people come together, put all of that stuff together, right? The collective intelligence that they have, if you were to say, and that's why I call it CRM for healthcare analytics. Okay, so the next 2 slides, these graphs don't look good, especially when I put it on the slide like this, obviously, right? I mean, it's really hard to see, but the point is, like I said, this is about being able to measure, optimize, improve the performance of an ACO that is there right now or that is going to be formed. Doesn't matter where it is in the whole state. First year, second year, third year, whatever the case be, right? As of now, we are going after the 33 ACO quality metrics. So imagine on the previous slide, you basically selected a number of dimensions without providing any data. You say, okay, if these are my operating dimensions, how am I going to perform from an ACO model point of view, all right? Right? So you get that. But once you start pumping data in, you go through the 8-step process, this thing becomes far more intelligent, right? And it really gives you clear insights into where your ACO model is going to be performing better or worse. Now, I'll talk a little bit about my MBA speech as I wrap this up. In MBA, right, we always say that, from an operational effectiveness point of view, it is not good to do benchmarking. Right? This is the famous MBA, or management guru speech, right? But I believe that this is one case where it actually helps to benchmark. It helps to know how the other ACOs are doing in this whole system. Why are some ACOs more effective, more profitable than the others, right? What makes that happen, right? It's hard to really understand that and unlayer that. However, I can give you something, a tool that is going to help you put your system together so that you can start driving your strategy, your ACO strategy. You can start driving that effectively and become profitable as an ACO. Yeah. That's it. Thank you. Questions? Yeah, please.
So if I got this right, this is just about the business formation of, and I'm guessing you're thinking Disrupt by the name of your company, but I don't know.
Yeah, absolutely. And you guessed that right.
Crazy,
I mean,
right?
I was somewhat involved with the whole Disrupt thing that's happening in New York City.
Yes,
so
in New York
that's
State.
that's in New York State. Thank
Yes,
you.
yeah.
That's a motivation.
So
for
it's
this.
just the business model. So that's why you extract only the demographic data and sort of where the patients are going.
Yeah.
And then you're just extracting the simple quality metrics that have been reported publicly.
Exactly. And adding additional data sources like things from Weight Watchers, public data sources that's available. There's a lot of public data that's available that I can get that national NPI, so on and so on. I can list them, not to go into details here, but there's so much that's available that is literally can be used and is of immense value as you're trying to, if I were to paraphrase, profile your ACO and you understand on a scale of 1 to 7, how is my ACO going to perform before I form it? Or how is my ACO performing in general, although my quality metrics look like, what do they look like today, right? So you want to get those critical insights. I mean, there is an element of analytics in this, but there's also the element of CRM. It's about enabling the power of this to the providers, to the payers, the ambulatory clinics, bringing those entities together. That's where I look at this as, is the sort of the CRM concept coming in place. It's a web-based online collaborative platform tool. No confidential data, no PHA data is required for any of this. This runs purely based on that. Obviously, this PHA data, it becomes more meaningful.
You selected an underlying database?
Sorry?
Your underlying database.
Oh, you mean what is my underlying
Yeah.
database? Well, right now this is on MySQL. However, there's no limitation from an IT point of view. It could be anything, that you want it to be, that I would like it to be. So, yes.
So let me understand. This is 3 weeks in development.
Yes.
You mentioned, as Aurelia said, ACO, but this is really for any.
MSSP ACO, Pioneer ACO.
So you really should consider broadening your
Absolutely.
slides.
Yeah.
The other thing that concerns me is, at least 7 or 8 times during your talk, you said, I believe my research, in my opinion. I know you're a humble guy, and I appreciate that, but what I'd really like to see is what kind of market information do you have more than my opinion, my research,
Okay.
so that I feel a little bit more comfortable that we're going in the right direction.
Sure.
And when is this thing going to, this program, this solution going to be in a more robust stage?
Thank you. So you asked 2 questions, and that's good. The answer to the first question, I actually had to do a thorough feasibility analysis, which I did not go through in detail here, but your observation is right. So I had to go through feasibility analysis that I actually had to submit for the NYU Stern to let me proceed to the next step. So yes, I included a lot of market data around research data. When I say, in my opinion, my observations, this is basically observations, what I've observed, what's being talked about, right? So publicly. Again, there'll be conflicting opinions too. I mean, everybody's not always going to be on the same page, to be honest, okay? But 80% is my rule of thumb. The answer to the second question that you asked, good question. So where I stand right now, I'm participating in this, or we are participating in this NYU Stern challenge. If you win this challenge at NYU Stern in about a month, I get $75,000. I'm also in conversations with a potential VC fund that's based out of Philadelphia. They have ties with UPenn, and they do some healthcare work. And if I proceed with that, then I get $50,000. The reason why I'm talking about this is prototype. The prototype works, but I want to basically create the whole thing, the full 8-step thing. And once it is done, it actually can be used by big or small ACOs, anybody, right? And there's different pricing models that I have for all of them. Pay-as-you-go kind of model, in other words. And so my goal, the goal that we have is we have a very strong intent to be profitable in 2015. Okay, so when I say profitable, that's an NPV positive, right? That's what I mean. Funding going in perhaps this month, we already invested some this month, more Feb and Jan of next month, but NPV positive coming out of 2015. And then from there on, there are different tiers of these, the end market that I have, right? So there are, the big companies go after any IT organization or hospital, healthcare, whatever organization that has more than $10-20 million of budget per annum. I'm not necessarily going after them. There's plenty in the middle section who don't have that big, deep pockets, who actually need something like this. They're the ones who don't have the capacity to go create a humongous system internally and spend 2 to 3 years on it. They don't have the manpower, the know-how, whatever, right? So I'm going to go after all of those markets next year. I mean, some, right? I need, to be very honest with you, I need 2 paid clients, no more than 2 paid clients to be NPV positive next year.
How many employees you have?
We are a team of 4 people, that's it.
Have you worked together before?
Oh, yes, we have worked together before. Actually, one of them is an acting CFO. I know her. One of the persons is my classmate at my MBA. He have formed his own hedge fund, so he's helping me make sure I get my financial stuff right. And the other person, I worked with him before. I also put in some applications to see if I can recruit some people, not yet, perhaps in 2015 for paid interns to make sure I'm able to get this developed properly. The thing about this is the classic case, build once, reuse multiple times, right? This will be built once, sitting online, anybody comes in, collaborates, does things. If I'm the CEO, COO of an ACO, I come in, start the whole thing, and then I can invite other collaborators into this framework to develop and make the ACO model rich. Right? This is I am convinced, the reason I say I'm convinced is obviously I don't have a paid client yet, so I've got to be honest, and I like to be honest about what I'm saying, right? Is that this will be one of the ways to make an ACO effective and profitable. Perhaps not the only way, there are other ways to do it. You can create a data warehouse, you can do a lot of fancy things internally. This is one of the intelligent, cost-effective ways that is going to make ACOs profitable.
Then in your next presentation, you're going to show us.
Absolutely.
That slide.
I actually have a total of, I'm running out of time, I'm sure. Thank you.
I have just one. I mean, you've tackled a very dense and important problem. I mean, you can tell your slides. Some of them look like the Krebs cycle, but it's it's important to us that that worked for us too. Otherwise, we'd be dead. And clearly, CMS needs to know what works and what doesn't work in accountable care organizations, ACOs. We all need to know. But a lot of people are trying to formulate best practices for for ACOs, and if it's going to work at all, CMS needs to know, ACO critics need to know.
This is
You're not working in a vacuum. There are a lot of other.
What you said is absolutely right. This is not to use any more of my MBA jargon in this, but there is true economies of scale and scope both, and this is going to benefit from the network effect. So I'm sure those of you understand what I'm saying. As more and more come in, just the model becomes intelligent. The data does not have to proliferate, right? The model any model has very different things. I won't go into details of the science of that, but that's, we hit innovation. We looked at how to sort of approach this problem in a way that no one else is approaching today. I'm talking today, right? Obviously, come 2015, Oracle or IBM have deep pockets. They could easily outrun me. Why not, right? But I've looked at different ways to sort of counter that threat. Co-opetition is one of the ways to do something with Tableau or so on and so forth.
Thank you, Rick. Okay, moving on. We're going to talk about a little bit of blood right now. So I'd like to have Om come up.
Hi, I'm Om. I'm here with my team, Dr. Miko, Dr. Joshila, and Siddharth Mitra, and Nancy Salerno, who couldn't be here. We're Clincis. I'm going to talk to you about a product we developed. It essentially helps physicians make decisions around blood transfusions. It's HEMSIS. The present situation with blood transfusions is that it's the 5th most overprescribed procedure in the US. Consequently, somewhere between 20 to 50% of blood is overutilized or overused, and prescriptions are, this is known for several years now. It's almost been there in the publications for about 10 years in papers. So a typical physician treating a person is more concerned with legislation, more concerned with information overload, with more concerned, like the previous presenters. He's not necessarily standing and doing his regular stuff. He's actually sitting on a computer figuring out how to fit his decisions into that equation of the myriad guidelines, the myriad processes that he needs to follow. So what we are talking about is essentially helping a physician make decisions better at the point of care, especially for blood. We would like to put the protocols in terms of a workflow for the physician and essentially help him through that process, making those decisions. So especially for the data that's available in all these different systems, EMRs, LIMS, you're going to pull information from all these systems and use NLP and all that stuff that we've been hearing about, so I don't want to get into it. But the important part about that data that's available, it's mostly stored. It's not used. It's not available for innovators or software companies to actually work with. So there's disjoint workflows. There's different things that are happening at different locations, which the physician has got to make a plan at the point of care. And the majority of clinicians are unsatisfied with the EPIC, as we've heard of, the EPIC failure or whatever they called about it. But I don't want to go into that. But the reality is only 2% of physicians today actually say that they can actually meet meaningful use. So given that fact, the solution is attempting to help a physician through his workflow with a protocol that's automated and algorithmically implemented for the physician. So when you talk about the solution, it's customizable by the physician, for the physician, especially the protocols are difficult, and they're actually made by a large group, a community that actually is vetted by the hospital system, and that protocol has to actually be abided by every resident, and it's not necessarily followed by everybody. So our solution essentially helps that. It bridges the gap by providing this application that the physician is consulting at the point of care, looking through his notepad or his phone or his computer, and is looking at the point of care and looking at the background monitoring that the application is providing him, is able to provide alerts, especially when the criteria are met, the critical alerts are fired off, And then there's continuous data analysis, so that helps in the background instead of the physician going or checking with the nurse with the current protocols that he has to follow. So they are real-time suggestions for the physician, very basic and ready, available for the physician to actually take action upon. Essentially, that's the solution for blood especially, because it has a little bit of controversy based on each institution. They have their own triggers, they have their own places at which they transfuse. Some people do it at 7, some people do it at 8. They have different changes in each different physician service. So this is our basic screenshot. Everything's available with the labs and the transfusion history, the signs and symptoms can be added. Of course, the indication has to be checked off. This is if the physician needs to check off. Now, the NLP part of it is actually we're inferring. There's an inference engine that can actually populate those points for us, which the physician doesn't necessarily need to, but depending if there are some customers who actually need, they don't have good, structured data fields, so you have to go mine the unstructured data to actually fill that. So everybody now knows what unstructured and structured data is. So essentially it pulls everything together at the point of care for the physician to make a simple decision, and only 3 clicks. Signs and symptoms, and go through the recommendation, and you're provided with some recommendation based on the protocol that's been automated at the back. So simple, straightforward for blood. Now, the value about this is it's actually a platform that we can actually improve beyond, because the protocols are the ones that we are actually automating for the physician, and the data that is pulling through and flowing through the protocols in our algorithm is actually being mined by our inference engine. So there are 2 parts of it, the inference engine and the data that is actually going through the flows of the clinical protocol. So that's essentially the problem here, losing money through blood. I wouldn't want to say it. I'm not a physician, so I can be fine saying it. If I was a physician, I wouldn't be saying that. So Medivare doesn't have a solution yet. They're trying to solve it through Strategic Solutions Group. Transfuse Solutions, a very small startup, is attacking it through the anesthesia and surgery part. Epic and CERN are still sleeping about this, but they're going to wake up later. Now, the chief's financial officers are essentially the ones who have to make the decision because, of course, there's money being lost. The chiefs of service, of course, want to enforce a certain protocol in their departments, and they definitely would like to have this. And, of course, the blood bank directors are definitely important because they're the ones who are getting badgered all the time of being a cost center, so they can actually reduce their costs, and that essentially helps us pay for our things, for our costs. So hospital administrators are the ultimate buyers because they are the ones who make the decision on this. And if you talk about the market, it's a percentage of dollars saved and a fee for service. Very basic. I've vetted all of these numbers through talking to customers and hospitals. There's about $1 to $3 million savings if you actually implement a reasonable protocol which is optimized through a restrictive transfusion, which are already published journals, which are, again, available. So average hospital would save anywhere between $1 million to $3 million for just implementing a simple restrictive protocol along with our solution. Now, again, you can see the numbers in terms of the hospitals. How many hospitals are there in the US? Just in the New York, you have 31 hospitals. We plan to start small. We're working with, we've actually done some work with one of the major hospitals in New York. We got some early information about how we can minimize the order sets. Orders that have been placed for blood. About 70% of the blood that orders were placed, we could actually show were not necessarily required per the protocol of their hospital. So that was the important part for us. Now we have our team, which is essentially helpful for building this product. Without them, I couldn't have been anywhere near the podium. Dr. Joshila is our medical person who helps us with the protocols and automates these things with Sid Mitra, who is our programmer, who will actually help us with all the intelligence in making these protocols real and live for a physician to use. Dr. Miko is our pharmacologist who will help us with managing anemia, which is an important part of managing blood, because most transfusions are usually provided for anemia's sake, and you just are pushing the trigger just because somebody's got low hemoglobin levels. Now, Ms. Nancy Salerno helps us entirely put this out for the world to see because she's an incredible communications person for us. And we got some traction with some of the folks who've been working with us. The professionals from all these institutions have been helping us come up with this. And we've been through NSF I-Core program and going through the SBIR program funding. Of course, we have a prototype that is working, and we are actually demonstrating through that. I'll leave that for questions at this point. And the most important part is the key takeaways, which is it reduces unnecessary transfusions, and it's a multidisciplinary team.
So, do I understand you to say that you're going to show the doctor the protocol is going to tell him he's not supposed to give the blood, and he's not going to give the blood?
Not
Because
necessarily.
I got some heart surgeons to introduce you to.
I exactly heard that. So yes, it's a recommendation system. You're right. It cannot be a requirement for a physician to make this decision based upon him. But the value about the solution is when you want to have a physician learn a particular behavior over the course of time. Of course, they've spent several years in school. They're very smart people. You cannot teach someone like that, except it's a matter of changing behavior. There's already available information. All one needs to do is reinforce it. And the reinforcement is coming through our decision trees, which are available for a physician to take a look at. If he's taking a look at the decision tree regularly, you would have done this, you would have done this, but why are you doing this? So that's essentially the issue.
How long is your longest running pilot? And in that pilot, what's the pain point that's coming up the most?
So this year, we have actually worked with a major institution in Manhattan, and the main pain point is the data that's not really clean. So if you're going after structured data, it's pretty straightforward, but there's a lot of, even in structured fields, they put in information that's not really required to be there. Physicians are doing this, and nurse practitioners are doing this, everybody's doing this, so we have to actually mine through that to come to understanding how it is. As far as the time we spent on it, with 3 months, we had work with one major institution, and the data basically gave us that there were so many orders that were placed, and we looked through those orders. I mean, we only tackled orders where they were outside the protocol about 75% of the time, orders. These are not transfusions that were already made, so I'd like to distinguish that.
So I think it's great that you've created some software to help clinicians fact check their basic assumptions through kind of an interactive checklist that you've gotten, and it's a very nice UI, but it seems like a rather simple system to copy if somebody wanted to do that. I mean, basically you're just taking protocols and you're saying, did you follow them? And if you didn't, maybe you should consider something else, which is terrific.
Yes,
but
so
it doesn't seem that hard for anybody to want to implement something like this, either in their own software or through another method to actually do.
Yes, so the point is it simple to copy? If you're just using the protocol and you're trying to automate the protocol, yes, but the protocols have been there for tens of years. And it's not necessarily the protocol that's actually helping the physician. They already know the protocol. It's actually the availability of information at the various parts of the protocol that's actually helping the physician. And that's what we're providing during the point of the decision making. It's a clinical decision support through the pathways of the workflow at the point of care. It's almost like I don't know if you guys have heard of HubSpot for marketing, or if you've heard of a CRM system that's telling you what not to do, what to do. I mean, you just came to my website, hello, let me call you. That's the kind of a system in the protocols that you've actually embedded in it. It's not so easy to copy. The protocol is probably easy to copy, and that's what all the CPOE systems do. They pretty much put up a screen with, hey, you have to do this. Did you check this? Did you check this? Did you check that? They've been there. They've been there for tens of years now. People are they're still over-transfusing. And that's where the value of part of the solution is in navigating that workflow.
Thank you.
One last question. Anybody? Okay. Thank you very much, Alan.
My company is dedicated to reduce or bringing molecular diagnostic to the point of care. So making it substantially cheaper so the sophisticated technology that it represents can be used in settings like doctors' offices and distributed testing, and make it for hospitals even a lot cheaper. And this may sound easy, but it's very, very hard because it involves a lot of very complex technology. We were motivated to get going on this because the trend in healthcare was obvious that healthcare requires better patient outcomes at lower cost. And it sounds like a paradox, but we took it on. And I must admit, we came from companies that make super expensive stuff for sequencing and real-time PCR in the research sector. And it took a while for us to accept the fact that we could be disrupted by such technology, and then we decided to disrupt ourselves. So when I was heading up an advanced research department in such a very rich company, I went to the boardroom and proposed I would disrupt the company, and it was not very successful, the idea, because I wanted to preempt being disrupted, and now I show you what will disrupt. Okay, so we developed a single platform that is sample to answer and is very, very easy to use. So the sample relevant for infectious diseases detection and diagnostics are gram-positive bacteria, gram-negative bacteria, double-stranded viruses, single-stranded viruses, DNA, RNA viruses. And our sample prep can all do this in a slight mix of a mechanical and a chemical way. We can do this in a very simple cartridge. I have one here, and I will demonstrate it to people individually because it's hard to see from a distance, but it's very, very simple parts. So the trick that we did, our innovation, was really to think about the very chemistry where the action happens, to then reduce significantly by orders of magnitude the liquid handling requirements, the fluidics, the optics. And as a result, since we were successful and we were able to also synthesize our own polymer, what we were able to do, come up with a consumable that snaps together out of 5 plastic parts. It has only 2 chambers in there, and we have a microarray integrated in one of those simple chambers. And it's a one-directional flow. That sounds like a lot of gibberish, but I tell you, this makes an instrument really cheap. Because now we did away with all of the fluidics, and what's really important is all of the components that go into this instrument are mass manufactured. We use the CMOS, a modified CMOS chip that you use on your smartphone. We use LED lights. We took a gamble 5 years ago and said LED lights would get better, cheaper. They did. And now we use simple LED lights, CMOS chip, and materials that are mass manufactured. This makes this instrument so cheap, despite of all these capabilities, that we will give this away. So with a it's not the typical rental model because this is, we can make profit on a very low cost. We designed this product to compete with technologies that are widely used by 80% of all the hospitals, like simple lateral flow flu sticks and things like this, and we can compete in price. But we do 25 to 50 assays per sample in one chip at the same cost. I want you to let this sink in. This took a lot of work and a lot of very experienced people having done this for many, many years. Okay, so now, the instrument is the size of a size 8 ski boot, maybe. The computer is integrated. Often when you see prospectuses from molecular diagnostics companies, they show you the analytical part. They don't show you the computer you need to run this thing with. The computer is integrated. It's all simple touchscreen operation. And I will show you some examples on how easy it is to operate. Another big advantage is it doesn't require a service contract. This thing comes out of a box, and it's plug and play. Yeah, so you need no service contract. You can yourself move it on the bench. I had videos to demonstrate it, but I have only 4 minutes. So this was another big achievement. So you can remotely access this. You can network these things. You can network them in your hospital on different floors. You can daisy chain them. You can network them across New York, across the world, across the country. The touchscreen, I'll show you some of the operation, hopefully. Is there any features I forgot to mention? No specialized training. So when you think of Ebola, I'll give you an example. A thing like this would look at 10 different strains of Ebola, would nail it within an hour. Sample to answer and easy to use. You could easily help this. It was really angering me when I saw one of the physicians die because it took a week to get the results for him. He liquefied internally in this week. For us to see this, it's really outrageous, right? But this is how this goes. Here's the simple workflow. You simply use a 50 microliter of a liquefied sample. So it's, we have done this with nasal swab, environmental swabs from surfaces, water and air. And we have developed a biothreat panel for the government because it was richly funded by the government, because they want such a technology out there and it doesn't exist. And we have done this with an upper respiratory panel with nasal swab. And we know it works with other liquids too. I can show so anyway. So you introduce 50 microliters into this consumable. You then close it and it will not open again. That makes it very safe. You put it into the instrument, you press go, and after an hour you will have 25 tests run against your one sample and you get a flu A outcome. But then we did the software in a way, because we also have to deal with the CDC. When you press flu A, you can look underlying data. You see curves much like TACMAN technology, which is quantitative PCR. So you see cycle thresholds and you get a sense of quantitation. That's also possible. You just press flu A and you see why it's positive and how positive it is. So this is a sort of a breakdown, since I already told you about this. So this is really interesting. There are so many innovations that could be done in the hospital sector. Whenever we talk to people that work on this, then we always run into LIMS, very complicated and archaic requirements regarding LIMS. So I show you this instrument does not prevent any kind of weird LIMS requirements. It anticipates like LIMS in the cloud and all these things, and we're ready for it. But we also have features like, this is of course barcode driven, so the instrument will know what protocol, what sample you're using, so you cannot use the wrong consumable with the wrong sample. And we totally anticipate a clear waiver. So the instrument has several self-check features as well. And I'll give you another example why this is so easy to use. And then you can add a barcode of your patient or whatever your system is. You can connect it to a printer and print out whatever. We have heard the weirdest LIMS requirements, and they vary. Sometimes they in Kaiser, they may vary. It's really fascinating to us. Anyway, it's tenfold cheaper, but here's the kicker. When you use molecular diagnostics to that sophistication, it's really hard to use. So one of our employees, his daughter is 7 years old. We have a one-page instruction sheet. She's smart, but she read this sheet and she ran it successfully. It was not a patient sample; it's just water. But just to go through the process, that's it. And that's the challenge that I think we have successfully met. We have prototyped successfully the CDC and the Department of Homeland Security. They have subject matter experts. Every milestone is thoroughly reviewed. And what I can tell you, this is working really well. We even had an Asian company that wanted to buy us. They had two people, their CTO and their business manager for diagnostics, come over, and they had literally patient samples in their pocket. They partially degraded. We nailed them 100%, and we showed them some co-infections that they didn't know about. Why? Because they didn't even have a multiplex PCR as a possibility to diagnose it. So I'm very confident this really performs. So in summary, I would like to say it's a high-performance technology and a low-cost, easy-to-use package. It's deployable anywhere. It can be run by anyone. It's safe because it's self-contained, and we have received funding from DHS, the Science and Technology Directorate. It's like a DARPA, a mini DARPA, and it was a lot. We spent like 30 million to get to this point. But since you are interested in return of investment, so that's not something we have to repay, we're undiluted. So I think that was very important, right? Because we had to think of original ways to fund it, because otherwise we're undermining our mission. And our mission is primarily to make healthcare cheaper, create better outcomes for less money. That's really the mission. And it's also why I'm here. I'm trying to find some original ways for non-dilutive funding or just people that are motivated in healthcare. We're in Silicon Valley, and I tell you the VCs in Silicon Valley, they're so blinded by social media and easy money that it's not a very good argument to say, I give the instrument away. So when I do the cost model and I project sales, then they go, wow, why do you give the instrument away? The government would pay us $25,000 for such an instrument. But the idea is economies of scale, and we can really do this because you can run this in Africa, you can run this in India, and it has very basic power requirements. And right now, when you even read it this morning in the hotel, I read the USA Today headline, they say they cannot diagnose properly. Still, so they put the Navy military over there, and they have to set up. You spend billions on solving problems that if Mark Zuckerberg, who's incidentally our neighbor in terms of building, if he would have spent the 20 million that he gave the CDC, that is funded by the richest country on earth, to us, we could have done this technology sooner. As I pointed out, an Ebola panel of like 20 different strains, we could have nailed in an hour. This is the bowling thing. So anyway, this is our mission. This is what we're all about, and I was really happy that you guys invited us. We have recently presented somewhere else in New York, and I must tell you, it's very impressive that people care about healthcare here. It's a really new experience to me, and it's really invigorating.
So how long have you been in business?
Doing this,
Yes.
May 2010.
And how many customers do you have?
This took a while to develop.
So is this ready
It's
for
a
market?
prototype. It's
It's
a
a prototype.
prototype.
When will it
In
be
a
ready for
year,
market?
we can do environmental testing because we don't, for an environmental product, because we don't have an FDA requirement. Within 2 years, then we can have FDA approval, and then within 3, you think we would have the clear waiver.
So you have IP protection on this?
Oh, yes.
Obviously, you can integrate easily into an EMR when that time comes.
Yes.
And what's the biggest obstacle you see
Money.
once you get money?
Money, funding. This place, so I tell you, very early on, we in our desperation and search for funders, there was a Chinese company that has 20,000 hospitals as their customers, and we wanted to do a joint venture, but we would have given up this entire concept, so we didn't do that. It's we want to do this here. I'm willing to get out the moment I see the first product, but not before.
Okay.
So within 2 years, an environmental product without FDA approval. Within 2 years, the FDA approval, right? And then within 3 years, a clear waiver. And I think that can move sales. You have to think of minute walk-in clinics, Walmart, things like this. And it's ambitious and it takes a lot of money, but it can make a lot of money because this is the way you get economies of scale with these features.
How much money do you think you need?
30
million?
Yeah. So I have developed similar products before, and it takes us typically 75 to 100 million. I didn't have a picture here. Our core team is 12, and that sometimes we were 20 because we use astronomy algorithms to do the spot finding on the array. But it's all available now. There's lots of these things, but you need a lot of skill to make things easy to use and simple and robust. And I want to, when the number appears big, I want to do this globally, right? I want to not just have 3 opinion leaders that I work with right now, but I want to work with 10 or 12 or 15. And that's the idea. Okay.
It sounds like you've been talking to investors, and it's an amazing, very well thought out product. It's it could help tremendously. It's just it's a great thing. Talking to investors, what would you say would be a reason why they wouldn't invest in, you wouldn't be able to raise the funding, if any?
Yeah, it's a good question. We are actively talking to investors, and I must admit there's some very interested ones. They're East Coast based for some reason. Go figure. But I'm not sure that I'm not believing it until the deal is signed and our values haven't been compromised. We have very good negotiations. We have next week. There's a final technical review by some industry experts that they hired and we agreed to, and then we should be ready for a term sheet. But I know they will push us to sell the instrument, right, and things like this. This is very cheap. I don't want to disclose the price of this. It's always a numbers dependent thing, but the hospital people will know when I tell you it competes with lateral flow, antibody-based, very crude things. That is really a statement, right? So it's funny. We need it globally, and it sounds sort of personally ambitious. But it's healthcare ambitious, right? We think this is a global thing, and the economies of scale could be. We can be profitable with actually a very conventional throughput calculation. I can tell you in a smaller group or so because I don't know where this information goes. Anyway.
Great. Thank you very much, Hans.
Yep.
See, Peter, we did get a little Ebola in here after all. So.
Thank you, at last. The promised Ebola angle finally.
There you go. Anyway,
and by the way, for anybody who's wondered, why can you get a color copy at Kinko's for 50 cents, but it costs more than $500 to get an X-ray of your wrist? I'm all for having low cost, good, ubiquitously available testing like this. It could do a world of good in every segment of our.
Okay, we're going to be tabulating the results, and in the meantime, I want to open it up to the audience. Ask any presenters any questions that you may have. Chris, are we here with mics? We have the mics in the back. So we want to pick those questions up. Chris, you around? Okay, Adam, you want to collect them? Okay, if you want to stand up and speak fairly loud while we get the mics, why don't you, sir, stand up? Why don't you come up here now?
This is a question, first a comment and a question for Hans. Hans mentioned that he presented at another event earlier. I was at that event. Hans came in first place in the HIT Lab World Cup, so congratulations on that. But I was just curious about what's the cleaning requirement of the machine?
That's a good point. As I said, this thing is self-contained, and if you use normal procedures like you would gloves and you apply that properly, nothing should happen. But you could conceive of a UV radiation tank or something if you need to do that. Inside the unit. No, but it's very, very safe. And so when you press this button, I had a video, but if you press this button, it opens like a sunroof, and then all you do is insert this, and it takes a very gentle motion to pull it in. You cannot misinsert it, you cannot do it misdirectionally. I tell you, the 7-year-old girl nailed it, first try. Actually, her whole soccer team did it, but I just had perfect shot.
Okay, other questions, sir? You want to come up to the microphone, please?
He's
the guy who said, I'll give you $10 million if you can invent a plane that can take people up into space twice in 2 weeks. You know what happened recently with the Virgin Galactic? He actually sold, so he's doing an X Prize for that technology, and basically saying, can you build a molecular diagnosis machine that's this size so that it can be deployed around the world?
Yeah.
And my concern would be
the size is an issue. So, I talked to some of these cities, and clearly Silicon Valley, can you make an app for it? Can you put it in your pocket? No. This is really hard work, and we have to go through these steps. And I can conceive, if you're interested, is it on? I can conceive of a handheld version of it, because if you go to outpatient, you need a much smaller sample. I tell you another really funky thing that happened. With this polymer that we developed to just immobilize. Oh,
Put
yes.
the microphone.
Yes, I guess, okay, I'm not good with that. Okay, a side effect, so this is a proprietary polymer, and the only way, because people in Silicon Valley think you have to be 15 years old and drop out of college in order to do stuff. I asked a 67-year-old guy to come out of retirement, and he was the inventor of the capillary codings of all the sequencing capillaries that were used to sequence the human genome in Solera. So a really clever guy, and I told him we want to make healthcare cheap, but that's how he came out of retirement. He did the polymer for us and went back to retirement. But here's the really cool thing. And we tested protein on it, and while you think it's a different property as molecules go, it worked very nicely. So we have, not that we really have to go in this direction, and it would distract us, but we have data where we can show you that with our LED optics, and we spotted, I think it was 12 different antibody solutions there, and we were able to visualize it as good with our LED optics as a $75,000 microscope that was being used for a fluorescent microscope. So there is potential where you can think of some of those applications. But if you, I don't know, it's not a very sexy thing to tell people you want to, very stubbornly insist you want to improve healthcare and make this cheaper, right? And we're kind of stubborn still, because we like the idea of giving this instrument away. By the way, the design was helped by a company that helped Apple design the notebooks. So we try to make it also attractive so it has a buying effect. I hope you see this or like it this way. I really like it, and I really. Other questions? So the question is to, we really want to focus on this and nail it because we can do gastrointestinal infections, we could make a sepsis application and things like that.
Other questions from the audience? Amy?
Well, this is a question for the judges. I noticed that in several of the presentations, they talked about how their services were cloud-based, and I was just wondering what you think about the feasibility and especially the security issues around cloud systems.
I think the cloud offers us an opportunity to provide services more cheaply, and that the same levels of security can be provided in the cloud if they're done right, as I can provide in my own data center.
I can speak from our institution that 2 or 3 years ago, it's not something we would even consider. But now, because of where we are with security and the robustness, it's something that's inevitable and something we're moving towards.
As a company that has a SaaS-based solution, we could, or early on, we did use that term when it was new and it would perk ears, but we stay away from using it because it it creates a lot of questions that we know we're secure. We've gone through third-party many security reviews and certifications, but it only opens up a can of worms that doesn't really need to be opened up. So it's early, but it's definitely an opportunity and a glimpse of the future.
So there's a risk-benefit equation that you can apply to anything, and absolutely the greatest risk to patients is not privacy breaches, it's the lack of getting data and information when you need it that could save your life. And you are at far greater risk because of all of the concern about keeping data private than you are from its being breached. And most medical errors are attributable to those people who are making decisions not having the information when they need it. And that includes patients. You don't get the information that you need, and clinicians. So cloud-based solutions are part of the solution to getting the data to where it's needed, and that's really where the focus has got to be on, not this, I think, over-obsession with privacy and security. It's going to hurt you a whole lot less than not getting the information and data that is yours and may save your life.
Okay, one quick housekeeping note, we'll continue with the questions in a second, is we do have more food and snacks back there. So, and number two, more importantly, is we have an after event at 9:30. We have to, unfortunately, be out of this lovely office space. But we are going up to Umbero, which is right up here on 42nd and 8th. And we'll have a little after event, so everybody is welcome and invited to join us up there. So please, and let's go back to questions. Anybody else?
Yeah, thank you. Alexander Sicular. I would like to thank all of our presenters and panelists for participating. We heard from a lot of presenters who are dealing with clinical data information, the difficulties in getting information, extracting information, working with information that are housed in traditional EMR applications. For those of you on the panel that represent large institutions, those institutions obviously had a role to play in this position that we find ourselves in. What are your institutions doing to open up those EMRs, to lean on those vendors, to get that data out of those EMRs so that they can be used by all these really interesting and innovative projects? Thank you.
So one of the reasons I come to events like this is I think sometimes you're operating with partial understanding of what our environments are really like. And I would tell all of you that a lot of the work people were alluding to here, we've gone a long way down, and you could learn some things from us. So we understand the data needs to be free. We've done a lot of work to free the data. We use our data. So, and in addition, I participate with vendors who provide open systems, web services, APIs, or you don't work in my hospital. So I feel very strongly about that. I think it's the future of technology, and that is an industry we're going to move in that direction. So they're all going to get there eventually. They're going to have to. I mean, that's where the world's going. So, but we're going to free that data, and we can help you develop these ideas.
There's a 21st century CIO for you.
Thank you. Thank you.
Hi, my name is Ram from Buddy Health. I have a question focused towards revenue cycle. We focused on that. For all the panelists who are part of a large facility, how much of a focus is on claim denials and keeping the ICD-10 deadline looming? Could you talk towards, is that still claim denials is a pending issue, or is it completely under control? Love to hear more on that.
Well, for our hospital, I think our revenue cycle is highly optimized. We're ready for ICD-10. We would have been ready last time. You know, it's a lot of testing and a lot of work, but it's just work. It's not rocket science, I don't think. So I think the interesting thing about the revenue cycle is in order to optimize it and to optimize it on some of our more traditional revenue cycle systems, we've had to do, we call them bolt-ons, you know, we add something to manage that and we add something to manage that. So I think the newer financial systems, and we're in the process of moving to one, provide those kind of workflow engines, like, you know, have TIFO built right in there and stuff, so we can better flex. And we need to have that because I think our reimbursement mechanisms are changing. So I think building these more modern, more flexible systems are going to be critical to keeping up. But we learned the last game. We play it very well.
Thank you.
So we're moving to a new EMR. We're going live actually with our first outpatient site in April, and I'm not going to sit here and tell you which one we're going to use because I'll only hear grief from the entire audience. But yes, we are going to that EMR. But the one thing that I just heard recently is that the revenue cycle piece and the integration to be ready by April 1st is a real challenge, and that's the one area where we're having we're spending a lot of time, a lot of money, a lot of resources to make sure that we have that ready and up and running by April 1st. So it's a big challenge, but obviously very important for an institution like ours, where 84% of our revenue is Medicare and Medicaid.
Thank you.
I just have one question for the judges. It came up a couple times in terms of, you know, the startups not really clearly identifying the market opportunity from a business standpoint and really trying to forecast out, you know, from a pricing and revenue standpoint where they potentially could go. And obviously there's a lot of variables involved in determining that type of a forecast. You know, I just wondered from one of your perspectives from a you know, investment standpoint, you know, why is it so critical, and this may be kind of elementary, but obviously some of the startups today didn't really focus a lot on that. And I'm just wondering, is it that we're too caught up in the technology or the problem and not thinking it through from a business opportunity standpoint?
That's a very good question, and from my background, I mean, I spent 10 years in Wall Street. So, but my reading of this was that you guys, I was under the impression, had vetted and received a business plan before this evening. And I suspect that now after the fact, that probably isn't true. And that, you know, what we were going to be seeing were companies that had either a track record or some kind of viability, possibly, I don't know if I would say long-term, but some type of viability, and that, may not be the case. So from my perspective, with my background as a business person, not an IT person, that's one of the things I do for Montefiore is vet a company from a business perspective before it even gets to the IT or clinical people to make sure this is a company we even want to be involved with. So going forward, I think that's something that's critical from my perspective that we should be looking at.
I think if you solve a real problem in a low-cost and innovative way, the rest of it, you can calculate an ROI in a way for you to make money off of it. But I agree. I think it's, is the problem real? Has it not been solved already in a better way by others? Or is a competitor going to come in and crush you because it's too easy to solve or too obvious? So those are the issues. But I think if it's a real problem and you have a terrific solution, and even if you have bigger, well-established companies who are going about it in an expensive or stupid way, as an entrepreneur, you've got a shot.
Randy, you've went through, interesting startup and you're scaling now and fairly successful. What would you say is your advice to the folks that are, really thinking through the challenges and trying to get over those barriers?
Piggybacking on Peter, I think, one thing is, I guess, it comes back to, I wish I would have heard more, and it's just not possible in this time, sort of this time frame, but I try to go on and read as much as possible, is the people and the team, and try to allude to a little bit of that. Those are very fundamental things, obviously biased, sort of, coming, we put a lot of effort and focus into our culture, but, we've seen firsthand, and it's no surprise that, companies, you need to zig and zag, you need to pivot, and your ability to do so under those pressures depend on the folks that you have and how committed they are. And there's a lot with the funding and how much money it takes to take something that's 3 weeks in and make it profitable, and so there's a lot. I feel like in this format, a lot of it is about getting a sense of the folks, see some of the subtleties and about the idea and how it fits in the market. But then there's a whole swath of people, the backgrounds, experience, and a lot of other things that go into it too. So, but if I were to give any advice, it would just be, for folks doing startups, it's just really you need to be dogged. You just can't give up, because hopefully it goes really smoothly. But I'm guessing in my case, our case specifically, it didn't really go too smoothly. So.
I would just kind of second what was already said, but in a slightly different twist. Where I get very concerned is when I hear stories that are not backed up by real solid data validating that what the problem you think is a problem really is a problem. Sometimes assumptions are okay, but most of the time they're extremely dangerous in the context of trying to build a product or build a startup. And so, again, that goes back to what I was saying earlier, that I really like it when teams stand up and talk about the number of conversations that they've had with different market groups, potential customers, really validating that they've been out, they've done the homework. And if you look at the Innovation Core model, which is an NSF program based on Steve Blank's Lean Launchpad, what we see in that kind of a program is that between 70, 75, 80 interviews is where you start to get relevant data, where you're actually moving away from assumptions and really into understanding, getting real data and a real understanding of what the product is, what the value proposition is, what customers will pay, who your customer really is. So when I say data, I mean hundreds of interviews to really validate that you know what you're talking about and that you're not making just assumptions about what you think is valuable.
Other questions from the audience? Okay, well, we do have a winner, I believe. Adam, correct? Yes. And the scores, so.
Great. And the winner this evening is NBS Technologies.
Just wonder, any of the judges want to just talk a little bit about why NVS kind of rose to the top?
Well, I think the earlier comment said it. I mean,
Yeah.
I think driving healthcare costs down is really critical, and there's some amount of money in process and some of the other things that we're going after, but moving healthcare into cheaper locations requires this kind of thing, and so whether it's Theranos or, you know, we got to change our model completely, and these are the things we need to totally change our model.
Yeah, in terms of potential, I mean, there are millions of patients every year who die and or suffer horribly from getting lab tests back that are either too late or wrong or aren't done because of cost considerations. If you could change that, if you could treat patients, I mean, if you know what you're dealing with clinically, you're just light years ahead of if you're just treating empirically or you're just guessing. So the opportunity to get better outcomes by making a technology cheaper or more available is a game changer. I mean, think of if you didn't know if you had a fever because you didn't have a thermometer. You know, and with antiviral, antibiotic, antifungal therapy, it's very much that way. If you're just guessing at a treatment, you have an okay chance of helping a patient. If you actually know what you're treating, you have a therapy which works, you have an excellent chance of making a difference. So I applaud anything that can make diagnosis faster, more accurate, and more available.
I agree. I agree with what everybody said. I think in addition, there's one last thing that I would add, and that is they clearly have a plan. And to sit here and say we're 3 years away, I think it's a plan. It may not be something that anybody in this room wants to hear, because we'd love to see the solution tomorrow, but it's a thought-out plan. There's a target, there's a market, and that's what put me over the top.
Yeah, one observation that I had, I think would like one of you to comment on it is, I think, you know, sometimes hospitals, from a public perception, get a really bad rap because there is innovation going on at hospitals today on a very accelerated, and it takes time. But I'm just wondering if one of you could talk to just some of the internal programs. I know Mount Sinai, just in terms of, you know, you saw some of the people here today who are working, and there's innovation, and there is, you know, pitchathons going on internally within some of these hospitals. And I just think that story's not getting out there, that the hospitals are really leaders in a lot of this technology today, and they are, you know, breaking new ground constantly. And I just wonder if you could kind of talk about some of the programs that you have at your hospitals.
I mean, I should qualify, I've been at Mount Sinai for 8 months, so there are a lot of programs that I'm not aware of yet. Mount Sinai is absolutely dedicated to building a robust innovation culture. We're investing heavily. We're building the Mount Sinai Institute of Technology. That's a partnership with the New York Economic Development Corporation that'll provide prototyping facilities for our investigators. We're reaching out to industry on a daily basis. We're, you know, it's, again, the number of programs is quite significant. You actually highlighted a couple of things that are going on. But I think one of the challenges is, as you say, getting kind of broadly getting the information out. Sinai is, I think, going through a transitional period. You know, with the merger with Continuum, we're one of the largest healthcare providers in the nation, and it's just investing very, very heavily in innovation.
So I have a particular view on this, and I think, so I work in an academic medical center, and we have 2 world-class medical schools, and they are innovating all the time. It is natural in healthcare, in medicine, to innovate around medicine. That's our history, that's what we've always done. We do that very well. I think where we get the rap, the bad rap, is changing the process. And so what, you know, CMS programs are driving to, and where I think providers get a bad rap, is we innovate on your care, but we kind of keep the same process going, right? So we haven't changed how we do visits very much. We haven't changed how you know, flow through the hospital very much. So that's innovation where we've done less. And I think that's mostly where people are kind of hitting at us. And then the second piece is healthcare IT is reasonably young, right? So EMRs haven't been around for a while. One of the things you find out, we did our EMR pretty early, the EMR is not where it's at. That's just not where it's going to be at, to your point. If you want to look out, that's not where it's at. So that's where the innovation, so we're now ready for a new level of innovation. We built the base that is fabulous for innovating, and that's where we need to start. And I think the opportunities are endless. Some of you guys are dancing around those ideas, those opportunities, but we really got to grab them. So,
Yeah,
but medical innovation, man, we do it all the time, every day, right? Your heart surgery is different today than it was a very short time ago.
Yeah, I would definitely add, I mean, completely agree with that. And keep in mind that in terms of innovation, you know, we have, whether it be Columbia or Mount Sinai or any of the major institutions in the New York area, a tremendous amount of basic science going on. So, you know, true innovation on a daily basis, whether it be in molecular diagnostics or immuno-oncology or what have you, surgeries, what have you, that is going on. It's part of our DNA. I do think your point about, you know, has your experience in visiting the doctor or visiting a hospital changed fundamentally? One of the challenges that exists around that is hospitals are very, very expensive things to build. It can be very, very difficult at times to change physical infrastructure in a large institution. I know one of the things Mount Sinai has done is to provide iPads, for example, to patients to help provide information around scheduling and what have you. So there's a lot of work going on in information technology. We're certainly working in everything from big data all the way down to molecular virology. So there's a lot of innovation going on, and I think you'll see that your experience in terms of visiting these types of centers will change dramatically over the next 5 to 10 years.
Okay, we have time for one last question, and unfortunately, we're going to have to wrap it up.
I just want to add to that we can get, we're all really incredibly lucky. You can get amazing, exceptional care in New York from just knock your socks off terrific hospitals. So we're very, very lucky to be here for almost any medical surgical condition. If you have a tough problem, there's no better place to be than New York. So thank you, hospitals.
Amen.
Yep. One last question.
Yeah, just real quick. I think it's really interesting. You've got sort of innovation, business development, incubators, and then you've got a CIO. And I've worked for 2 very large health system CIOs, and the world seems to be moving in very different directions. 5-10 years ago, every department, every specialty had these great ideas about, hey, I just saw this product at this conference, I want to buy it. and they all had their own budgets. They all went ahead and bought it. And as a CIO, you now have 2,000, 3,000, 5,000 different systems that you need to make sure are running on your network without causing problems. And so you implement system SRD processes. You have an information security office to try and make sure that everything is running well. It sort of becomes an anti-innovation type attitude in healthcare IT, especially in these larger health systems that are the product of all these mergers. The more you merge, the more systems you've inherited, and they don't necessarily interoperate. How do you feel like you can still allow incubation, you can still allow innovation, yet you kind of have to start shrinking that inventory of assets because it's just not sustainable?
You asking me?
I'm asking you, yeah.
So I think you're describing an evolution in healthcare IT. And so at one point in time, the informatics people in the world were inventing the basics of what we have now. And then you do have to sort of bring it together, make it more functional. I'm trying to explain to people that I have to harmonize hundreds and hundreds of systems. That's my job, and I have to do it, and they have to be secure. But then you go to a new level of development, and I really think that's where we are now. And so you take you're not really quelling the innovation. You're just saying that stage of the innovation is over. Let me package that stuff up, and then I'm ready for a new level of innovation. And so I see it more that way when you say that. Now, I don't want everybody going berserk and doing, a million crazy things. So I do have to have some control, but I do think I can set up parameters where you can innovate within those. And I think I can help you guys innovate better if you understand our environment and don't build something that when you come to me and some doctor comes to me with an idea and I go, whoa, that thing, people go, oh, we're going to screen scrape. I go, no, you're not, right? So whatever that evolution is, I got to go through that. The CIOs of our industry. Does that make sense?
Well, is there any advice you could give to the innovators in this room how we should position our products to make sure that when it gets to the CIO, they're going to bless this idea of
So I think when he was speaking about doing hundreds and hundreds of interviews and really knowing the facts, that's what we want, right? So, you can run around and yes, there are problems with EHRs and you can say, yeah, all the doctors are complaining. So, well, that's not the whole truth. So you better come in and get the whole truth before you just give me platitudes. And that's going to make a big difference in how well I receive you. And so if have you talked to Allscripts about their API? Do you know how to get those APIs? Go do that homework. You can do that homework, but don't come into me with, a white sheet of paper and a crazy idea. No, I don't have time for you.
So we have a slightly different approach. Slightly.
This will be the last.
Yeah, this is the last question. Yeah.
About a week and a half ago, there was a workshop out in Newport Beach, California, and there were 31 academic medical centers and providers that attended, all with either wanting to start innovation centers or who had already developed innovation centers, from the types of Mayo and Cleveland Clinic and UCSF and UCLA, Scripps. There were 31 of us that went out there to talk about what we're doing in the area of innovation. So there are basically two types of innovation. You have tech transfer, so you have internal and innovation. And many of these institutions, I was really very surprised, but the physicians are actually yearly. The part of their compensation and bonuses are on how many discoveries they've come up with over the year, which really promotes this idea of innovation. And then you have a second side, which is external companies that come into the organization, where you either co-develop, develop relationships, develop pilots. So what we're trying to do, and it's really in its infancy, is develop some type of a department outside of IT not within the IT department, where we would have a business, IT, and clinical person that would look at each type of opportunity to be able, before it gets to the IT people, before it gets to the clinical people, wasting all of their time, to at least vet these companies at a very high level. So once we do that, we can then bring it to the IT people, bring it to the global people, but we've already done the first level of vetting, so we're not wasting, individuals' times and levels of frustration increase. But it's an iterative process, and it's one that we're just beginning to tackle today.
All right, I want to thank everybody. We had an incredible panel of judges. Let's give them a round of applause, please. I want to thank all of the startups today that pitched. I know what it takes. It's a lot of hard work to get here. So thank them. And the sponsors, Goodwin Procter, MedStarter, as well as Cipher Health. Thank you, Randy. And we're going to follow up with our after party at Umbero's up at 11 Times Square West on 42nd Street. I encourage you to come. And Adam, you wanted to quickly say something?
I want to thank everyone for coming tonight again from MedStarter. And I think it was a really interesting conversation tonight. Tonight's event was called the Mega Challenge, and I think there were 2 challenges issued here. One is the startups and the innovators challenging the hospitals to how they deliver care and the experience of care. And I think the hospitals said tonight that they welcome that challenge on that point. And then the hospitals challenging startups to really understand how care is delivered and how the workflows work.
And thank you to all the volunteers, Mimi, Rachel, David, everybody, thank you very much.